Hi, good evening, everyone. It's 7 o'clock on Monday, the 23rd of August. Can I get a quick sound check, please? Someone just throw in. Fabulous, thanks very much. Quick response there. That's brilliant. Glad you can hear me. So, welcome along. Just having a little look through. We've got a very international crowd tonight, which is brilliant. Thank you guys for coming to join us in your respective time zones. I'm sure there's some quite early in the morning, late at night times for people here. So and of course, good to see a lot of the familiar faces again. So welcome back. We've been away for a couple of weeks. We've drunk plenty, eaten lots, and got sunburnt. So we've done everything we should have done on holiday, I think. So and it's good to be back and rested and ready to get back to normal. So welcome back. So tonight is the next in the series and the penultimate in this little mini series of pathophysiology. So we're doing genitourinary medicine this evening, or gum stuff this evening. So it's not a particularly long session tonight. There's not huge amounts that we need to cover. We'll do one session next week on trauma pathophysiology, looking at some of the stuff around the trauma patients face that we need to be aware of. And then we're going to move on from pathophysiology into some more subjects, which I hope that you'll find useful. And the first of those is maternity care, which I'm quite looking forward to. So that's in a couple of weeks from today. So those of you that are new to the channel, welcome along. We are STC Training Solutions. We are a pre-hospital care training provider based here in the UK. And we predominantly provide the FREC range of training to people looking to come into the UK ambulance services and event medical cover. And we focus on FREC 3 and FREC 4 at the moment. This series was put together to help those of you going through the FREC pathway with a vision of being particularly helpful for those of you working through FREC 4. With FREC 4, you have to do a set of workbooks, and you also have to keep a regular CPD portfolio together to keep your qualification valid when you do finish the course. So we hope that those of you in that boat are finding this useful. And I know we have had some people, some technicians and paramedics, etc., coming along over the last few weeks as well, which has been really good to see. And hopefully you've been finding it useful as a refresher for you. So for those of you that haven't seen or met me before, my name's Innes. I'm a paramedic practitioner by trade. I used to work for London Ambulance Service and still do on a bank contract, but work full-time in a GP surgery now in the southeast. So a lot of this is stuff that I'm kind of dealing with day to day, and I think genitourinary medicine is something that certainly as a paramedic I never received a huge amount of training in until I got into primary care, and I think certainly those of you at ETA and technician level probably in a similar boat. It's not really a system that we get a huge amount of training in, because actually, to be fair, there's not a huge amount we can do outside of hospital, and that's probably why. So we're just going to go through some common conditions this evening that affect the genitourinary system, and give you some pointers on what you can do to help these patients. So oops, once people come out of freezing, there we go, perfect. So we do have a couple of courses coming up. Obviously, the webinars are free, but of course, it does make it possible if we do end up with bookings off the back of them. So we do have courses coming up. We have a FREC 4 starting in a couple of weeks, actually. So obviously this course is aimed at people looking at doing their FREC 4, so if that applies to you and you're free. Then we do have a weekend FREC 4 course starting on the 4th of September. It's over 5 days. We deliver it over the recommended 7 weeks that Qualsafe suggest. So the 4th and 5th of September, 18th and 19th of September, and the 16th of October are the dates that you would need to attend our training centre in Aylesbury. In between those dates, we do have online contact sessions and some support with your workbooks, which you'll be completing in your own time in between those sessions. Those of you that haven't started out yet, our next FREC 3 with space, and it is filling up quickly, is on the 25th of September. Again, that's over 3 weekends, or we have a Monday to Friday course, which is nearly full now, actually, on the 11th of October. Already have your FREC 4 and looking at doing your SARM, then hugely popular, of course. That one, we get lots of interest in those. Our next one is starting on the 11th of September, 3 weeks. That's just £150. And ILS, you just missed one, so the next one is in a couple of months now. On the I've got my text box covering the date there on the 17th of October. All of our courses at the moment are running from Aylesbury, but of course we can travel around the country if sufficient demand comes up. So enough of the plugging, onwards and upwards for this evening. So welcome to the series. As I say, those of you that are new to it, this is a series of subjects we picked which we think will be useful for those of you going through FREC. So we've covered already CPD requirements. That was our first of this new series. We've been through some anatomy and physiology, and we're just coming to the end of our little mini series on common pathophysiology, which is the study of disease. As I say, a couple of weeks' time, we're going into maternity care, which I think you'll find useful. We're going to look at some patient assessment, paediatric assessment. We're going to look at some sepsis. We're going to look at oxygen and Entonox guidelines. We're going to look at some basics around ECGs, and we're going to look at intermediate life support. Just as a refresher, as I say, it doesn't replace your need to do an annual ILS or equivalent qualification to maintain your FREC 4 and FREC 5. Okay, so tonight, as advertised, we're going to look at some urinary tract infections. We're going to look at kidney infections. We're going to look at renal colic, prostate problems, ectopic pregnancy, and we're just going to briefly discuss sexually transmitted infection at the end. So again, the reason we don't traditionally get a huge amount of training in this area is actually because there isn't a huge amount we can do, but there are some things that you that you might find useful tonight that you can spot, and some bits and pieces that might help in just managing these patients if you do come across them in your day-to-day jobs. So lovely. So I'm just checking in on the chat. So Devon, no, we went to the New Forest and then we went up to Suffolk, Paul. So we had a little bit of a mixed one. So that went very quickly, of course. So this evening, so we are interactive. We like these webinars to be interactive. I will keep an eye on the chat box, and so do feel free to pop any questions you have as we go along in there. Once we get to any natural pauses, I'll do my best to answer them for you. We also use Mentimeter, so if you have a smartphone with you, just get that ready. Go to menti.com and I'll give you some codes as we go through to answer, and there'll be some interactive quizzes as we go through. It makes it more interesting, obviously, the more people that get involved with that. If you want to get in touch with us after the show, you can tweet us at STC Training, or you can message us on WhatsApp. You can email us at any point if you come up with any questions or anything else that we can help with. There's some recommended reading. Those of you, again, going through FREC pathway, sometimes it can be quite hard to find reliable sources of information. We're lucky in that Ambulance Care Essentials and Ambulance Care Practice, which are the two books that are most commonly given out with FREC 3 and FREC 4 courses, do contain the vast majority of the information you need for your qualifications. But further reading, we find Pathophysiology by Rachel Story and Ross and Wilson's Anatomy and Physiology are very useful to have in the library, either as an ebook or they're available to purchase in their printed copies through our website with free delivery. So do have a look at those if you're interested. So let's get interactive then. So grab your mobile phones, go to menti.com, and I'm going to give you a code to put in once my computer wakes up. So hopefully you can all see that. So go to menti.com, put the code in at the top of the screen, 72165048. That's 72165048, and answer the following question through the app for me. So what are the functions of the genitourinary system? So just a bit of a recap back to A&P. What are the functions of the genitourinary system? You can put up to 3 answers, I believe. So let's give everyone a minute to do that. So if you have any questions, do throw them in the chat as we go through. Lovely. Electrolyte balance, excretion and fluid balance, great. Some good answers there. Removing waste, good. Going back to the filtration system of the kidneys, very good. So absorption, removing waste, lovely. Any more for any more? So if you're just joining us, the first quiz, you haven't missed anything yet, we're just getting going. Menti.com, use the code 72165048 and answer the question on the screen. What are the functions of the genitourinary system? Homeostasis, good, I like that word, always comes up. Hormone control, good, absolutely. So don't forget, this is the genitourinary system. It's not just the urinary system we're talking about here, we're talking about the genitals as well. If that's going to give you any hints as to some of the answers that we could come up with. Lovely. Reproduction. Fab. Someone's gone for it. Good. Perfect. Absolutely. So the genitourinary system, most definitely, it forms the urinary system, which is obviously the kidneys. Starts with the kidneys that they filter the blood of waste products and also excess fluids, and also have a large hormone control over the body. And that waste is filtered down into urine. The urine is passed down through ureters into the bladder, where it's stored until such time as we can empty it through the toilet. And of course, the genitals as well, which are often considered as part of, well, they are considered part of the genitourinary system. We often link the two together. The genitals is obviously responsible for human reproduction and everything that goes with that. So we're going to have a little look at that now. So fab, well done to those of you that answered there. Let me just get back onto the PowerPoint. And here we go. Here's a little graphic again of the urinary tract. So the two kidneys there. The one on the right is slightly lower, as you can see. Somebody did once tell me why that was, but I think it was a bit of a hypothesis as to why one kidney was lower than the other. And then we had the ureters joining the two to the bladder, and then we have the urethra, which travels from the bladder to the outside world. Now, males and females are similar at this point. Obviously, the female ureter is a lot shorter than the male ureter, which has to travel up and down and through the prostate and out through the penis. Whereas the female urethra obviously just travels straight to the outside world, has a much shorter passage. And that does explain, which we'll talk about very shortly, into why females get more urinary tract infections than men do. So there we go. Welcome along, Sadie. No problem. Okie dokie. Whoops, click too far over. Computer's playing up tonight, so I do apologise. It's all been a bit jerky. So that was the urinary system. The genitals, again, with just a quick recap on the left of your screen, you've got the female reproductive system, which is obviously made up of the two ovaries, which produce the eggs once a month. They travel down the fallopian tube, during which time the uterus forms a nice thick membrane, which is rich in nutrients. So should that egg become fertilized at any point during its travels, that will nestle into the uterine lining, and of course the fetus grows from there. Most of the time, thankfully, otherwise we'd have a massive population issue. Most of the time, that egg does not get fertilized, and it just travels out of the uterus, and of course the lining breaks down, and it's that blood and clots and bits and pieces that are ejected monthly as the woman's period. With the men, fairly simple system, to be honest. Well, both are fairly simple, although they are prone to certain problems. So the male system is that we're continually, rather than with the females, where they have a finite number of eggs, and those eggs are released once they're all released, they hit menopause. With men, we continually produce sperm. The sperm cells within the testicles, they're mixed with the seminal fluid up in the vesicles, and then that becomes the ejaculate, which is obviously used to fertilize the egg. The penis is used for two functions, obviously for ejaculate and also for passing urine from the bladder via the prostate. So the prostate, think of that as a bit of a fancy valve that decides which of the fluids it's going to leave. Obviously, they can't both leave at the same time, thankfully. Normally, obviously, most of the time, it's passing urine from the bladder. Good. And I think there's nothing else really to go into on there. That's just a bit of a recap from anatomy and physiology. We did cover all of this a few weeks ago now. So the next question is coming up now on the screen for you. So the next question is goodness me, computer is not having fun tonight. I'm going to ask you this question. So cystitis. Cystitis is an infection of which organ? So you can choose from the liver, the bladder, the kidney, or the stomach. Have a vote now. So menti.com 72165048. Is cystitis an infection of which organ? The liver, the bladder, the kidney, or the stomach? Let's see how many of you have come across this. I dare say a lot of the women in the room will know this one. Tends to be more of a female issue. So how are we getting on there? 10 of you voted so far. So have a little go. If you're just joining us, welcome along. I can see the number is still going up slightly, a few late arrivals. So we haven't missed a huge amount. We're just getting started with infections of the urinary tract. So go to menti.com, use the code 72165048 and have a little answer. Let's just see where people are going. So most people are going for the bladder, some people are going for the kidney. Any advance on that? Nobody thinking liver, nobody thinking stomach. Good, not so many people voting tonight, that's all right. So those of you that have gone for the bladder are absolutely correct. Cystitis is an infection of the bladder. And we can see on this slide here. So urinary tract infections. So they're nice and simple, really. The urinary tract infections are just infections within any part of the urinary tract, and that's separated into the upper portions and the lower portions. So upper portions would be the kidney and the ureters, those tubes that pass the filtrate from the kidney to the bladder where it's stored, and the lower urinary tract infections, which include the urethra to the outside world and the bladder itself. All right. So lower UTIs, the two common ones are urethritis and cystitis. Cystitis by far the most common urinary tract infection that's diagnosed. And what effectively happens is bacteria generally enter the urethra, and they travel up by osmosis, etc., up into the bladder. Again, I mentioned earlier that it's much more common in females. That's because of the shorter urethras, and obviously the bacteria has less far to travel before it can colonize the bladder. And the bladder, of course, is a nice warm environment. It's a moist environment, and it's an ideal bacterial breeding ground. So once cystitis sets in, it can be a little bit problematic to get rid of, as I'm sure people that have had urinary tract infections and recurrent urinary tract infections can testify to. Let's say not exclusive to women, but it is far less common to see urinary tract infections in men, and it is somewhat of a red flag actually when you're assessing patients. If you have a male patient who's not catheterized with a urinary tract infection, we do often consider whether there is, it's not always, but whether or not there is something underlying that's causing that. So I mentioned catheterization. Catheters, obviously, indwelling catheters that travel up the urethra into the bladder are very likely to bring with them some bacteria. So obviously we try and do aseptic technique as much as possible, but it is very, very easy to introduce infection via the catheter route. So patients that are catheterized often have recurrent UTIs. In a lot of elderly folk in particular, urinary tract infections can be associated with some quite noticeable changes in their cognitive state, particularly patients that already have an element of dementia type disease. Urinary tract infections can definitely exacerbate that. So you often see that. It's the characteristic that the old lady in a nursing home with a UTI tends to be quite cognitively impaired as a result, and settles down nicely once she gets the appropriate antibiotics, of course. So urethritis and cystitis, as I say, being the most common, it's just bacteria traveling up the urinary tract. As I say, much less common in men, much more common in female because of the vaginal and anal flora that are around the entrance to the urethra. So the upper urinary tract infections are definitely a lot less common. Pyelonephritis is the posh word for a kidney infection. We're going to talk about that on the next slide in a little bit more detail. But pyelonephritis can be quite nasty. It's associated with damage to the kidneys if it's not treated quickly enough, and also quite a good cause of sepsis. Pyelonephritis is quite a good cause of septicemia and full-blown sepsis if left untreated for too long. Urethritis is a rare condition, but it's inflammation of the ureters themselves. Again, it can occur in combination with pyelonephritis, but as a standalone illness, it is actually quite rare. But again, certain bacteria, if they travel up through the bladder, if it's untreated lower urinary tract infections such as cystitis, if they take hold and the body's natural defenses don't look after it, and that bacteria colonizes and spreads rapidly, they can easily travel up the ureters and cause urethritis and pyelonephritis. So it's something just to be aware of when you're taking a history. If the patient started with what sounds like a classic UTI, and don't forget, a lot of people don't bother getting antibiotics, they just let it pass. But if they've had a few day history of lower urinary tract symptoms, and now this has progressed up to flank pain and high temperature and feeling generally unwell, then of course we would have to consider upper urinary tract infections, which, as I say, are a lot more serious. So the kidney infection itself, I've just popped a little couple of diagrams up there. The pyelonephritis is actually inflammation of the functional parts of the kidney, and this is why it's a little bit dangerous. So it's the nephron, which I put on the right side of the screen. We're not going to go into any detail about what the nephron does, other than it's how the blood is filtered and how a lot of the potassium and sodium balance is maintained within the body. And of course, in maintaining that sodium potassium balance, to maintain the fluid balance, blood pressure, and a lot of other things. So if that nephron is inflamed, it doesn't work correctly. And actually, you can imagine if you mess up your sodium potassium balance, if you mess up your electrolyte, your water balance within the body, you're going to cause a lot of problems that don't just affect the kidney itself. But of course, pyelonephritis, if left untreated, can cause scarring and permanent damage to the nephrons, and of course that will reduce your kidney function and result in an AKI, which we definitely don't want. So acute kidney failure and sepsis are the two main complications of pyelonephritis. So recognition and early treatment is quite important with these patients. So just to be aware of. So here's some recognition features. So again, just over on the left, your little kind of golden bubble there of signs of infection. If you're thinking a patient has infection, always screen for sepsis. We use NEWS2 to screen for sepsis, and anyone with a score of 5 or more, anyone with an individual red component to NEWS, should be treated as potentially having red flag sepsis. Obviously following your local policies and your scope of practice as to what you do next. So with pain and infection, of course, we're going to see a raise in breathing and heart rate. That's to be expected. Obviously, if it becomes extreme levels, then they're going to start triggering high NEWS scores. Blood pressure might drop in. Again, if pyelonephritis particularly spreads to sepsis, you're likely to get that dilatation of the blood vessels and a drop in blood pressure. Unlikely to see ECG changes with patients in this group. GCS, again, if you start to drop your blood pressure, you might start to lose GCS if patients are particularly unwell. But again, you're thinking sepsis then, and you're treating the sepsis in the immediate stage rather than the pyelonephritis as such. Blood sugars are unlikely to change. Again, there is some evidence that blood sugars can rise even in non-diabetic patients with infection, but it's not a reliable marker. So raised temperature again. So lower urinary tract infections are associated with low-grade fevers, absolutely, and you can get high temperatures up to kind of 38, 39 with lower urinary tract infections, but the higher temperatures are certainly much more associated with upper urinary tract infections, such as pyelonephritis again. So typical classic signs of a urinary tract infection are burning or stinging when you go for a wee, needing to go more frequently with urgency, i.e. you're not sure you're going to get there in time. You might see visible blood in the urine. And you might have a temperature, you might have some lower tummy pain, you might have some lower back pain. When we start to get flank pain, so back at the bottom of the ribs at the back there around the thoracic spine, that's when we start to think actually are the kidneys involved, and particularly if our temperature is going up. Pyelonephritis is associated with nausea, vomiting, high fever, and as I say, that flank pain along with all the other urinary symptoms that you'd expect to see. So management plan. Management does really depend on how unwell the patient is, to be fair, don't we? But always we're going to start with calming and reassuring and moving to a quiet environment. Again, asking a lot of the history you're going to be taking with genitourinary presentations isn't for the public ear, is it? So it's generally something you're going to want the patient on their own for, away from anyone that they don't want to discuss it in front of. So as with all patients, a good history and a full set of observations is really going to help you start to make decisions around what's going on once you understand this underlying pathology. Always calculating a NEWS score, particularly when there's infection present, because it does help you to figure out which ones are really sick. Pyelonephritis, as I've mentioned, can be an emergency. It can result in acute kidney damages, and of course can readily cause septicemia and sepsis. So urinalysis, i.e. doing the urine dipstick, depending on where you work, you might have access to urinalysis. It's not the be all and end all. I know that if you look at a lot of the NICE guidance now, actually we should be diagnosing UTI based on the history more than actually the urine dipstick, particularly in the elderly. But no, certainly if you want to use urinalysis to support your diagnosis, absolutely more than welcome to, and you're looking for leukocytes and nitrates in the urine to suggest infection. It might be possible. It might also see some protein and some blood in the urine dip as well, which is not uncommon with urinary tract infections. But we do like to see that returns to normal once the treatment's completed. So again, safety netting and follow up your patients is important here. Pain relief may well be necessary, particularly with pyelonephritis. You can get some quite nasty flank pain and lower back pain with that. So Entonox again is your friend. That's nice and effective, quick and easy to administer. Paracetamol is safe to give with anything like this generally. But again, we avoid the anti-inflammatories just in case there's any bleeding or just in case there's any acute kidney damage going on. They tend to be a little bit more renotoxic. So monitoring your patients closely, particularly if they're unwell, but bearing in mind not all urinary tract infections well, certainly not all urinary tract infections will need hospital treatment. A lot of UTIs will clear up by themselves, particularly in young, healthy adults. But of course, those that have established illness or other comorbidities going on that make their immune system a bit more compromised will certainly need antibiotics and a little bit closer watching. But if we're thinking upper urinary tract infections, we're almost certainly going to be looking at hospital for bloods and possibly IV antibiotics. Again, considering your paramedics there for support for pain relief. So obviously paramedics in the UK can often carry a lot stronger pain relief than technicians and ECAs do. And for some clinical decision making there if needed as well, CDM clinical decision making, if there should always be somebody on call that you can speak to discuss these patients with if you need to. So we're going to move on to the next one, which again is often sometimes a little bit hard to differentiate but renal colic or kidney stones, good old kidney stones, is these calcium buildup that people get within their kidneys. Now, some people are more predisposed to it than others. It's not fully understood why some people get loads of kidney stones in their life and others don't ever get them. But certainly high salt diets are associated with them, as are high cholesterol and generally being unhealthy can put your risks of kidney stones up. And also there's a bit of a familial link as well. If you come from a long line of ancestors that have all had kidney stones, then the chances are you'll be at higher risk. So it's a build up of calcium within the kidney itself. They generally don't cause too much issue until they enter one of the ureters, and actually in entering the ureter and stretching the ureter causes intense pain. So it tends to be a very sudden onset of sharp stabbing pain around the flanks, because it's all going to start from the base of the kidneys and travel down the ureters towards the bladder. So you get this sharp, intense pain stabbing you in the back and radiating down towards the groin. They become particularly painful if they do get blocked, but generally most of the time patients pass the the kidney stones without any external input. Although it is intensely painful, it's likened to the same type of pain as childbirth. I'll have to take people's word for that, but it is thought to be one of the worst pains that you could experience. Again, a lot of these patients, whilst 9 times out of 10 kidney stones will pass uneventfully by the patient themselves, it is often appropriate to scan these patients, or almost always appropriate to scan these patients, just to find out how big the stone is and to decide whether or not any external input's required. So we're often not going to leave these patients at home is the bottom line. These patients may need to go into ambulatory care or A&E to be assessed by somebody from the urology team. So in terms of recognition features I've discussed there, other than heart rate and respiratory rate going up with the pain, other observations aren't likely to change. You're not going to get a temperature, there's no infection here present, but you are going to have that intense sudden onset of flank pain radiating down into the groin. There may be visible blood in the urine again, in fact there normally always is. And there may be some nausea with the intensity of the pain going on. So clearly one of the keys here is to administer pain relief. So Entonox, again, rapid onset, easy to give, easy to get hold of normally. Paracetamol is absolutely safe to take. Stronger options such as morphine are almost always needed, to be fair, if we're going out to them as an ambulance service. Again, monitoring those patients as required. With renal colic, as I say, our local pathways, renal colic pathways are for those patients to be scanned. Our local guidelines where I work is that they get scanned within 24 hours, but again, the ambulance services may well have different protocols. And ultimately, if you're thinking the patient's in significant pain and needs morphine to control that, you're certainly not going to be giving someone morphine and leaving them at home. So that's going to be an ambulatory care or A&E admission for some imaging there, just to see whether that's going to pass naturally or whether they're going to need some input to help with that. Again, considering your paramedics there if you need them for that additional pain relief. if you've got a long journey to hospital, it's always going to be nicer for your patients. So. Moving on then to the next section this evening, which is prostate problems. So obviously only affects men. Men have the prostate, which I've said is a fancy valve. Basically, it selects between whether you're going to have semen passing through down into the penis or whether it's the bladder emptying urine. Now, the prostate, as you can see in that little diagram on the left, normally has a little tunnel through the middle, which is where obviously the fluid can pass. When we get inflammation or enlargement of the prostate, basically that tube becomes narrowed, and it can result in problems with emptying the bladder. And if you do get urinary retention to the point of the urine flowing back up to the kidneys, you get hydronephrosis, which is effectively swelling of the kidneys with filling up with fluid from not being able to empty down into the bladder, and that can cause, again, significant kidney problems such as we saw with pyelonephritis. And apart from anything else, it's really, really uncomfortable. If you know what it feels like to be desperate for a wee, and then imagine that you can't actually pass urine, how intensely uncomfortable that must be. So urinary retention is normally the most problematic factor of prostate problems. So there are two main types to consider. So we have inflammation of the prostate, which is prostatitis. Tends to increase in prevalence from about age 45 onwards. Infection of the prostate or something else causing the prostate to be inflamed. And as the prostate swells, it basically squeezes down on the tube that passes through from the bladder onto the urethra effectively. And limits the flow out from the bladder itself. And of course, that is intensely painful as well. The prostate is quite well innervated, and prostatitis can be extremely uncomfortable in the back passage and around the perineum. And the other one to consider, which is really common in older men, is prostate cancer. So that's something we have to be aware of. Again, from an ambulance point of view, but we don't really deal with cancer in those stages. We deal with cancer in the end of life care stage more than anything. But prostate cancer is something to be aware of, and you can get prostate enlargement through non-cancerous causes. And it's generally termed as benign prostatic hyperplasia, or BPH. You'll see it down as, and effectively that is just enlargement of the prostate for benign reasons. But ultimately, in a lot of those patients are going to require TURP, which is a procedure, TURP, which is a procedure where they bore through the prostate and reopen that hole to allow the bladder to empty properly. As I say, the most common presentation of these patients is that they're going to be in acute urinary retention, and of course in prostatitis it's an infection, so you might have all the classic signs of sepsis as well. So there's things to be aware of there. Again, think sepsis and calculate your use too if you've got someone with an infection. Again, it might be painful. So again, the urinary retention side will definitely be painful. So raised breast rates and heart rates are possible. Of course, if there's infection, that's going to further that. Again, observations otherwise are generally going to be quite normal. Prostatitis isn't normally associated with sepsis, but again, it does require early treatment. Otherwise, it can spread like any other infection can. So normally you'll have seen all the adverts on the TV, no doubt, that men, particularly if you're peeing blood, you need to see a doctor. That's because of the prostate cancer risk. And we check your prostate when we do a blood test called PSA. If you're presenting with acute urinary retention, that's one of the things we're always thinking of. Is there a tumour on the prostate, or is the prostate just benignly enlarged, or do we have an acute prostatitis going on? So signs of prostate problems in men are, as I say, blood in the urine, sensation of incomplete emptying. So you feel like you've not quite emptied your bladder, you need to go kind of 10 minutes later. Dribbling after urination is a classic thing. Struggling to get going, you hear men, and to be fair, all men get a slight enlargement of their prostate as they get older, and that classic presentation of you stand at the toilet, you want to go, but it just takes forever to get going, and then when it does get going, you've got that weak flow. So there is something called the IPSS score, the International Prostate Severity Score, which is worth taking a look at if you do come across these patients, or if you're assessing these patients in the ambulance. So good. In terms of management, not a huge amount, to be honest. So again, we're looking for any signs or symptoms that mean they need urgent admission. Now, acute urinary retention, clearly you can't leave these patients at home. There are some community services that offer catheterization in the community. There are some specialist practitioners working for ambulance services that can catheterize. But again, normally there's some fairly robust criteria as to when they would attempt that. Almost always from experience, patients with acute urinary retention, we would take them into hospital, get them a bladder scan, get them catheterized, and then start to figure out why they've gone into urinary retention, particularly with the older men, looking for any signs of prostate cancer or just generic enlargement. Pain relief, again, I find that there's not really any pain relief that works with patients in urinary retention. Even high doses of morphine don't really tend to get rid of that sensation, that need to empty your bladder. We know from end of life care that actually there's a couple of sensations we really struggle to get rid of, and that is the need to go to the toilet. Number one or number two, it can really make patients quite uncomfortable, even those that are quite moribund and very close to end of life. It can make them be very, very difficult to get people comfortable. So actually there isn't a whole lot. We'll chuck pain relief at patients, of course, in situations like this, but there's not a huge amount that can help until they're catheterized, really. So in terms of benign prostatic enlargement, in terms of prostatic cancer, if we're thinking along those lines, again, if we're not looking at the acute urinary retention side of things, actually the GP is the one to manage these things. We have something called the 2-week wait or the 2-week rule pathway, which is mentioned there, and that's for patients that we think might have cancer. We can get them seen within 2 weeks by a specialist. So again, 9 times out of 10, you're not going to be called on the ambulance because somebody thinks they have prostate cancer. I mean, I'm never going to say never, but generally you're going to be called because something acute is going on, and it's likely to be that urinary retention or a bleed. Urethral bleed of some sort. So again, considering your paramedics for pain relief and clinical decision making, that's what we're there for. So fab. So we'll break that up. Let's have a little go at Mentimeter again. I hope you're finding this useful. So we've got the next question coming up on Mentimeter. So you're back on menti.com, 72165048. 72165048 on menti.com. Answer this question for me. You've got a 25-year-old female. She presents with lower abdominal pain and diarrhea. Which of the following are we most concerned about? 25-year-old female, lower abdominal pain and diarrhea. Which of the following should be jumping to mind? Ectopic pregnancy, ruptured AAA, cervical cancer, not cervical cancer, goodness, cervical cancer, or infectious diarrhea and vomiting. Which of the following should we be most concerned about? Have a little vote there. There's a little over 50 of you. Let's see if we can get a good number of you voting. Good. So grab your smartphones, menti.com, enter the code 72165048. Let's see where we're going. Bit of a split. So about 60-40, yeah, catching up now. Which are we more interested in, ectopic pregnancy or infectious diarrhea and vomiting? So nobody's thinking a 25-year-old female with lower abdominal pain, diarrhea has ruptured AAA, which is good. And I agree that cervical cancer wouldn't be my first thought. My first thought would be, is this an ectopic pregnancy? Okay, so well done to 57% of you. And here's why. So ectopic pregnancy then, what is ectopic pregnancy? First of all, it's when the egg is released and it becomes fertilized. Sometimes, and sometimes for reasons unknown, the fertilized egg nestles in the lining of the fallopian tube as opposed to the uterus itself. Okay, now that's not sustainable. That's going to result in miscarriage, and normally that happens uneventfully. Occasionally, though, and again, reasons unknown. Every now and again, you get that fertilized egg will nestle in the fallopian tube and it will stay there. It will start to grow. Okay, so the reason why this becomes a problem is the fallopian tube is only designed to stretch by a very small amount. Okay, so if you start growing a baby within your fallopian tube, eventually it's going to rupture, and when it does, the blood supply to the uterus when a lady is pregnant is as you'd expect, pretty substantial. And a lot of the defense mechanisms that the body would normally have, a lot of the clotting cascade, etc., has changed somewhat around the uterine blood supply, because ultimately the baby needs to have blood no matter what. So often what can happen if you get a significant bleed around the uterus in pregnancy, the body doesn't switch off that bleeding in quite the same way as it would, or it wouldn't shunt things in quite the same way as it would if you weren't pregnant. So you can lose significant amounts of blood, certainly life-threatening amounts of blood, very easily from a ruptured fallopian tube or ruptured uterus. uterine lining, etc. in pregnancy. So again, we don't fully understand why sometimes ectopic pregnancies develop. We know that there is a somewhat of an increased risk with the coil. So ladies of childbearing age that have the coil in situ, we do see occasional cases of ectopic pregnancy there. But again, as I say, normally it doesn't carry the body in its own way, gets rid of it and it sorts itself out. It's just those ones that latch on and start to grow that can cause us problems. And it generally causes problems at around 8 weeks gestation. So these patients are going to have positive pregnancy tests. That's the key here. So and one of the things I want you to just bear in mind is any lady of childbearing age that you go to is going to is with abdominal pain is going to be considered for ectopic pregnancy until proven otherwise. Now, good history taking may well rule out ectopic pregnancy straight away. We have to believe what our patients tell them, and if they say they've never had sex or they've not had sex in the last, God knows how long, clearly they're not going to be pregnant. We don't need to pursue the matter anymore, but we do need to just be considerate of our environment there. If you're talking to a 15, 16-year-old girl in front of their parents, quite clearly, you may not get the correct answer, even though she may be happy to tell you on their own. They're not going to say it in front of their parents. So do bear in mind the environment when you're asking those types of questions of your patients. So in terms of, so why diarrhea? Good question. So again, not fully understood. It's thought to be something to do with pressure being placed on the perineum, the protective layer around the stomach organs, or the abdominal organs, sorry. The protective layer around the abdominal organs, the peritoneum. Pressure being put against that from the expanding fallopian tube is thought to trigger increased peristalsis and diarrhea. So diarrhea is quite a common presentation in kind of peri-ruptured and ruptured ectopic pregnancies, as is, for a very interesting one, left shoulder tip pain. So you may well hear, you'll certainly read it in the books, you'll certainly hear it out on the road, patients with lower abdominal pain, diarrhea, and shoulder tip pain, absolutely barn door ectopic pregnancy. The reason we have ectopic pain, again, is pressure on the peritoneum, and the way that some of the areas of the peritoneum are innervated in terms of sensory neurons. You can get radiation, or you can get kind of referred pain, sorry, to the left shoulder tip with ectopic pregnancy, which is quite an interesting set of events, really. So those three things to consider. So swelling of the fallopian tube, putting pressure on the peritoneum, causing diarrhea and shoulder pain. That's your classic kind of presentation of ectopic pregnancy. That being said, the ones I've dealt with, I don't think have all had all three. I don't think I've ever seen a patient with that classic triad of all three symptoms going on. But certainly just have in the back of your mind, that's the take-home point, have in the back of your mind, any female of childbearing age with abdominal pain, always ask yourself, could it be ectopic pregnancy? You can normally rule it out very quickly, but sometimes it just lingers there and you think, it could be. If you're thinking it could be, they need a scan. It needs to be ruled out completely. If you have the ability to do pregnancy tests there and then, yes, a negative pregnancy test does reassure you somewhat. But again, if you're thinking that's what's going on, get them in, and it certainly is time critical. So recognition features of ectopic pregnancy, again, they tend to present around the 8 weeks, and that's generally because the fallopian tubes are expanding to the point at which they can't expand anymore. If they go on anymore, they rupture. Rupture causes bleeding, and the bleeding would be to such an extent that they could actually die from that. So high respiratory rate and a high heart rate, both with the pain and with the hypovolemic shock that could be developing. So those are things to look out for. Look at your News 2 score. There's no infection here, so you're not expecting to see high temperatures. But if you're seeing high News scores in these patients, think, are they bleeding? And we need to do something about that. So as I say, left or right, lower abdominal pain, diarrhea, shoulder tip pain are common. The sharp stabbing pain, it's fairly rapid onset, particularly with rupture. And those patients will deteriorate rapidly. Cardiac arrest could be a possibility. So we do need to keep these patients monitored. I'm not saying that all patients that present with ectopic pregnancy are going to arrest in front of you. They won't, but do be aware that if something ruptures and they bleed significantly, they can go downhill quickly. All right, so that's that one. Your management then is just going to be the usual stuff: calm and reassure, quiet environment, a full set of obs. Pain relief, again, Entonox is going to be useful. But again, with all abdominal pain, we've got to exclude bowel obstruction, haven't we? That's one of the contraindications of Entonox. Paracetamol is safe to give. Again, if you're thinking anything to do with bleeding, avoid aspirin and ibuprofen just because of their antiplatelet properties. They'll mess up the clotting cascade even more. And if you can't exclude, ruptured ectopic pregnancy, we do have to treat that as time critical. They need scans, they need surgery, urgent surgery, if that is what's going on. And as I say, a good history can often tell you enough as to whether we go down the route of ectopic pregnancy or not. But just bearing in mind the environment when you're getting that sexual history, do just have a thought about actually when do we want to ask this question, and you often see scenarios where the question's been asked in front of the parents, and then you have to make the parents disappear, and then of course the parents are thinking, well, have they just given a different answer? So try to avoid that in the first place. Just try and get the question in when you're not around parents or people that the patient doesn't want to talk about it in front of. So go to paramedic support. Again, if your patient's crashing, you definitely want paramedic support there for lines and ALS, of course, should it be needed. So, and then we're coming to the end now. So we're going to talk about sexually transmitted infections. They are very generic, unfortunately. This is why a lot of STIs go undiagnosed in the UK. So I've put the three kind of main common ones, I suppose, that we come across in primary care and that cause us issues. So anyone that you think has an STI, I mean, I can't think I've ever been called as an ambulance person anyway to something which I thought was a sexually transmitted infection as the reason for call, but you certainly end up talking to patients about some benign symptoms that they're putting off, and actually you might think in the back of your head this could be an STI. So any patient you think could be in that group, there are sexual health clinics all over the place, GUM clinics all over the place. At the moment, particularly because of COVID, obviously a lot of them are asking that you phone ahead before you just turn up, but a lot of them were just walk-in centres. So have a quick Google, have a quick look at what you've got in your local area. Obviously, if the patient is acutely unwell, then we're going to consider ambulatory care or A&E as appropriate. But vast majority of the time, suspected sexually transmitted infection don't need to go to hospital that day, but they do need to be seen or at least triaged by the sexual health clinic. I'd say probably the main ones that we see in primary care are chlamydia, gonorrhea, and syphilis. They're the ones that are still quite prevalent out there. Chlamydia and gonorrhea are predominantly they're very very common STIs out there. So the trouble with both of them is they present quite like urinary tract infections. So one of the questions we ask, particularly of young patients who are having urinary tract symptoms, we're always keen to get a good sexual history there and find out whether there's any chance of chlamydia or gonorrhea, and actually there often is a chance. It's any episode of unprotected sex can give that to you. So chlamydia is I think still the most common in the UK, if I'm not wrong. It's certainly between chlamydia and gonorrhea. It can be asymptomatic, i.e. not give you any symptoms. A lot of patients don't know they have it. And that's actually why it spreads so well. The patient that gave it to you didn't know they had it, genuinely didn't know they had it, and it's only because you tested positive that actually you go back and you do your sexual tree of who you've had sex with in the last however many years, and it's then that you go back and they figure out that they've also got chlamydia, and they may have been the one that started it all. So it can cause, commonly when it does cause symptoms, they're very similar to urinary tract infections, burning and stinging. They can cause unusual discharge. They can cause intramenstrual bleeding in women. But again, with chlamydia, it can cause serious complications if you don't treat it early. So it can cause something called reactive arthritis, and it can cause infertility. So we do need to treat it once we know it's there. So gonorrhea, again, more common. It's more likely to be symptomatic. It's characterised by this classic greenish discharge for both men and women, which is obviously not something we tend to ignore. Again, bleeding is common, particularly in women, instrumental bleeding. The real big nasty side effect of gonorrhea actually is if you catch gonorrhea and become pregnant, that you can actually make your child blind during the birth process. So if you have gonorrhea and you give birth, you can cause blindness, and that'll be permanent blindness in a newborn baby. So of course we want to make sure that all expectant mothers are clear of gonorrhea. So, but again, more likely to be symptomatic, it's less likely to miss gonorrhea than you are with chlamydia. And syphilis, again, it's less common, but it is still around. We do get positive cases fairly commonly within primary care and within the sexual health clinics. So again, can be asymptomatic, but it's more likely to cause kind of warts and sores and things like that around the genitalia. It also characteristically has a bit of a rash, a reddish rash on the palms of the hands and soles of the feet. And some generalized kind of aches, pains, feeling generally unwell. It's generally the type of stuff people come to us because they're feeling a bit rubbish, they're feeling a bit run down, and by process of elimination, we try and figure out what's going on with them, and occasionally syphilis comes back. So again, serious complications if not treated with syphilis, more so than the other two. It can cause brain damage if left untreated. So all three can be treated, all three can be readily tested for. Again, if you're coming across patients that aren't sure or they have something like that, I know a lot of you doing FREC3 and FREC4 will end up working in nightclubs and other things to do with young people where a lot of these things spike. So definitely worth the conversation with them, reassuring them that things are easily diagnosed, easily treated, and to encourage them to get some help with that. So we'll flick back to Mentimeter for the last time then. So last question coming up then tonight. So one more just to check you're all on the same page. So which of the following is the most important consideration when you suspect pyelonephritis? So patient with suspected pyelonephritis, which you remember is the kidney infection, which is the most important thing to check? So their blood glucose level, their tympanic temperature, their NEWS2 score, or their GCS. Which of those is going to be the most useful for you? Have a vote now. Menti.com 72165048. And which of those do you think is the most important when you suspect pyelonephritis? A few more voting this time. Let's see where you're going. Oh, look at that. Very good. Very good, everyone. Absolutely. So 100% getting it right there is obviously a good one. When you are considering pyelonephritis is associated with septicemia and sepsis. So absolutely get your NEWS2 score in if you've got any concerns. Total over 5 or an individual score of 3 or more, we would suspect red flag sepsis and make sure those patients get the appropriate treatment. And we've come to the end. As I said, it was going to be a relatively short one tonight. There isn't a huge amount I can really teach you that I think you'll find useful about genitourinary medicine. I think in an ambulance service setting, recognition of a couple of things. I think pyelonephritis and kidney stones are important. Recognition of ectopic pregnancy could well save a life. Don't dismiss that abdominal pain as gastroenteritis and leave them at home. That's without properly exploring the chance that it might be an ectopic pregnancy are really the take-home messages. So that's it for genitourinary medicine. Next week, as I say, we'll be back Monday the 30th, week today at 7 o'clock with some trauma pathophysiology, which hopefully you'll find useful. There's some interesting stuff coming up in there about fractures and immobilization. We will then be back the week after with maternity care, as I say, when we move on from pathophysiology. All of the episodes so far are on our YouTube channel and through our website, the CPD Home section. You'll be able to find all of the YouTube videos there, excuse me, and get your CPD certificates. So if you have any questions, now's the time to ask it. Pop them in the chat or email us if you don't want to do it publicly, and we'll get back to you. And other than that, we finished. So if you're along for the evening and that's everything, then you're free to go. Yes, it will be. Everything's recorded, Julian. Yes, next week we are a bank holiday, but no, everything is always recorded. So you're more than welcome. What I'll do, folks, just before you disappear, is put the link for the free certificate into the chat. Bear with me. Let me just find it. Okay, copy link. So in the chat, I've just put the link to claim your free certificate. So if you click on that now and then just fill out the feedback form, you'll be able to download a PDF certificate of attendance. There will be a link on Facebook as well. So if you do miss that, I'll pop it on Facebook and it'll be on our website, of course, once we upload the YouTube recording, which will be in the next day or two. So if you do miss the link now, it's not the end of the world. You'll still be able to get your certificate later. And of course, if you go back and watch any of the previous videos, again, wherever you watch it on YouTube or on our website, you should be able to find the CPD certificate link somewhere nearby that you can click on and fill out the form. So I hope tonight's been useful for you. Certainly, you know, before I came out of the ambulance service into primary care, I didn't know a lot about genitourinary medicine. I think it's useful just to have an awareness of some of these conditions when you're out there. Yeah, good luck when you're out there treating your patients. It sounds like you're all doing a wonderful job, and you're all over the world, which is brilliant. So if there's anything I can answer for you, then please do throw it in the chat. If not, I hope to see you next week, and obviously face to face at some of our courses in the future. So next week at 7 o'clock, if you are joining us. Otherwise, have a good evening, and I'll take questions.